for organizing the conference, Lady Malloch Brown, and Dorothy and Lara. I'm going to talk about cranio-cervical fusions and 5-year follow-up, but also give a little bit of backup. I do have a few disclosures, patents relating to cranio-cervical junction and devices. My goals today are that you understand that connective tissues disorders manifest with lax ligaments, and that these may subsequently result in pathological mechanical stresses on the central nervous system. I want to discuss what constitutes cranio-cervical instability and the outcome of 20 patients that we followed for 5 years. Well, first, why did I get interested in this? And I think you'll see that my interest is very organic. In fact, it began right here in London at the National Hospital and also Maida Vale. And Alan Crockett asked me to look at the histopathology of 10 patients who died as a result of basilar invagination. And he said, you'll find evidence of ischemia. And actually, we found no evidence of ischemia, but we did see these silver staining specks here in the dorsal columns and in the brainstem. And we opined that these were actually axon retraction balls and were the result of a stretch injury. No one believed me at the time, but we relied heavily upon the work of Professor Alf Brieg, who showed that even with normal flexion of the neck, there's stretching of the brainstem up to 10% of its length. And in addition, there's also stretching of the lower cranial nerves. And he felt that the brainstem and upper spinal cord were on the edge of pathology all the time. He also explained that any out-of-plane loading, such as from a retroflexed odontoid or a disc or tumor, would cause compression of the central nervous system, and in a viscoelastic system, it would increase the longitudinal tension, and as well as causing contralateral histopathological changes. Now, the combination of increased tensile stress or strain plus out-of-plane loading is called the von Mises stress, and we'll get back to that. Now, a few years after the paper we published, Pavlychuk gave electron microscopic evidence of stretch injury, and looking at neurons, he found that the internal architecture of the axons had collapsed and the neurotubules had collapsed, the microtubules, and so stretching caused loss of axoplasmic flow, and this axoplasm would then clump up and form these small axon retraction balls, and this is the basis of the strict nodule in the brain, or diffuse axonal injury. And a few years later, Satman showed if you stretch a mouse optic nerve just 20% of its length, that's a strain of 0.2, that 3 days later you'd have these axon retraction balls. And our colleague Jenian Ford Geddes Montague showed in babies that had died from shaken baby syndrome that the underlying cause of the death was actually injury to the corticobulbar axons, and then apnea causing hypoxemia, and then secondary cytotoxic edema, that the children were dying from swelling of the brain, not from subarachnoid hemorrhage. So on a much simpler level, Dr. Howard and I and others showed that in a group of 12 patients with rheumatoid arthritis and compression of the ventral brainstem, all of these patients had sleep apnea, and with the transoral odontodectomy and removal of that mechanical deformation of the brainstem, the sleep apnea resolved. Now, Wolf and others showed that with stretching of the nerves, mechanical deformation, there was instability of the sodium channels leading to loss of the electrochemical gradient and influx of calcium, as shown on the upper right there. And this calcium activates the calcium-dependent proteases, and which precipitates neuronal injury. Arundine showed that stretching nerves actually has a kind of epigenetic effect, and he found upregulation of N-methyl aspartate and other compounds. So NMDA actually makes the nerve more sensitive and more susceptible to peroxynitrates and free radicals, and also makes the cell more vulnerable to mitochondrial dysfunction, DNA fragmentation, and in fact apoptosis. Swift showed that there's an demonstrated the importance of mechanical deformation in the morphogenesis of the brain, and Pahlavian commented that the mechanical milieu is very important in the regulation of the genome and gene expression. Now, we're familiar with studies of peripheral nerves where stretching the nerve decreases the compound action potential, and this decrement occurs with increased magnitude of strain, and the application of a very rapid strain greatly increases that decrement in magnitude of the compound action potential. So all of these concepts we discussed in stretch injury associated with cervical spondylotic myelopathy, and it's safe to say that in the United States and hopefully Britain, that the importance of mechanical deformation and stretch to central nervous system injury is established. Now, I want to differentiate, however, that pathology of diffuse axonal injury due to distraction, things like spinal cord injury without radiological abnormality, stretch myelopathy, deceleration injuries of the brain, that's quite distinct from injuries of trauma and focal contusion or ischemia. We, in 2010, published a series of 7 patients who had presented with brainstem compression, and we actually developed a finite element analysis program to predict mathematically the stresses of the brainstem and upper spinal cord. And we predicated the study on the notion that a kyphotic flexion deformity results in stretching of the brainstem and spinal cord. And Professor Brieg had shown this, but there's also the element of the top of the odontoid pressing back into the brainstem, causing an out-of-plane loading, and this combination of strain and out-of-plane loading is von Mises stress. And several researchers have shown that central nervous system injury correlates very well with pathological increases in von Mises stress and also the maximal principal strain. So this is one young man, 9 years old, who's in the emergency room once or twice a week with apnea and cardiology issues, and it was quite dire looking. When we did the mathematical finite element analysis several months later, but it showed predicted extremely high stresses in the brainstem due to the pressure on the ventral brainstem and that small Chiari in the back. And after surgery, a reduction, fusion, stabilization, the predicted stresses dropped to normal level. And when we looked at all 7 patients, we found a statistical significance in improvement of the sensorimotor Asia scale, the Karnofsky performance scale, and the physical and mental component quality of life. And these correlated with statistical significance with the improvements in predicted stresses, von Mises stress. So I hope that I've made a case that mechanical deformation and stretch causes organic injury to the brainstem, and this is actually very recoverable. Unlike ischemic injury, which may be more permanent, a mechanical stress and deformation injury is rapidly recoverable. So who are the patients we're talking about 2 decades ago, we were talking about rheumatoid arthritis with pannus formation and cranio-cervical instability. And there are very large series that discuss those cases. But there are also 50 hereditary connective tissue disorders, and about which not much was known until some members in this room, such as Professor Graham, who's developed so much of the knowledge of Ehlers-Danlos syndrome. Anyway, we published on the most common neurological and spinal problems that we're seeing in the more severe end of the spectrum of Ehlers-Danlos syndrome. And keep in mind that these syndromes, I believe, are not rare, and some of our leaders in the United States were thought to have Marfan's, and one exceptional athlete may actually have certainly a hypermobility spectrum disorder. They breed horses with EDS because they win. We know a lot about osteogenesis imperfecta and Marfan, and the closely related and recently defined syndrome of Louis-Dietz. And these patients have dissection of the ascending aorta and these aneurysms in the chest and abdomen. And the Stickler syndrome with problems with the hearing and vision, flattened cheekbones, and the Pierre-Robin glossoptosis. There are 13 types of EDS. Many have scoliosis. In fact, there are 4 types that present primarily with weakness and scoliosis. So any neurosurgeon or spine surgeon has probably encountered many of these patients, but maybe not understood the underlying connective tissue disorder. This is one of my patients, and where there's a dissection of the renal artery. She had vascular EDS, but I've operated on a number of those and have actually done well. Fortunately, the hypermobile form of EDS is the most common, and Dr. Rodney gave a beautiful lecture on that, so I won't go into that, but I do believe that the prevalence is much more common than 1 in 5,000. And I was surprised just last year to diagnose my own nephew with Ehlers-Danlos syndrome. And it turns out that many of my friends have children or cousins or friends with Ehlers-Danlos syndrome. And so I think that, and all of these patients, even though I've made the diagnosis many times, I've sent them off to geneticists for confirmation. So I think that Ehlers-Danlos syndrome is more on the order of 0.5% of the population, which is shockingly high. And that's based on about 2,000 patients that I've seen from all over the world. Most of my patients do have partial orthostatic hypertension with thought to be due to dilation of the blood vessels and pulling of the blood. But as Professor Matthijs said, the dysautonomia is actually much more complex and involves many parts of the central nervous and peripheral nervous system. Most of my patients have syncope or pre-syncope. This is a paper by Van der Pep and Francisca Malfay, one of the earlier, this is only not even 10 years ago, showing the deformation of the brainstem and the stretching of the brainstem over the odontoid. Now, it's not surprising that, given that ligaments are the major occiput to C1 stabilizing structures, that if you have a disorder with a primary collagen problem, they're going to have some degree of instability at the cranio-cervical junction. And Punjabi showed that if you cut the alar ligaments, you get rotational instability at the cranio-cervical junction and the atlantoaxial junction. And the Punstock showed that the occipital atlantal capsular ligaments were actually probably just as or more important. So what does the NIH think about EDS? They say it's misunderstood and undiagnosed by the medical community. This disease goes undiagnosed because of the difficulty caused by multi-system involvement. But the study of EDS is potentially useful as a model for looking at many genetically acquired connective tissue defects. So what did we find in our study? We published our results earlier this year online, and we paid to make it available free online, so you can pull this up without having to pay for it. These were 20 patients back in 2011, 2012 that we followed over 5 years. There are 19 females, because this disorder affects mostly, well, it affects male and females equally, but the women suffer much more from it. The average age was about 25. Most of the patients were like this, sort of homebound, in bed, or on the couch, and needing a great deal of care from family members. At follow-up at 2 and 5 years, we had a 20 out of 20 response, and I did the exam. The radiologist measured the indices of instability. Third-party nurses performed the online surveys. Now, inclusion criteria included that they had exhausted non-operative treatment, and I suppose that's a reasonable amount of non-operative treatment, but most had been carrying on for many years and had seen dozens of doctors and tried every treatment available. Surgery was understood to be a last option, and they all had headache greater than 7/10. They had the cervical medullary syndrome, about which we discussed this morning, in which I agree it's a fairly vague grouping of symptoms, but it does reflect pathology of the cranio-cervical junction in general. All patients must have, or all had neurological deficits and congruent radiological findings. So at the consensus meeting in San Francisco in 2013, we agreed on a number of symptoms which, taken together in aggregate, reflected cranio-cervical pathology, and this is the cervical medullary or cranio-cervical syndrome. So, but when does hypermobility at the cranio-cervical junction become pathological? And I want to stress that hypermobility is not instability. And the whole, I think, understanding of instability should be taken in the context not simply of radiologic metrics, but also the neurological manifestations of the patient. So instability, I believe, should reflect some neurological disability on the part of the patient. We achieved a consensus statement with 17 different institutions in 2013 in San Francisco, and agreed that these three measurements, which were beautifully described by a neuroradiologist this morning, help to give us understanding of potential pathology of the cranio-cervical junction. And again, if you don't have an upright Med-Serena MRI, then the poor man's flexion extension CT scan or MRI shown here will get you about 70% of the way there. So the clival-axial angle is simply the angle between the lower third of the clivus and the back of the odontoid, the posterior odontoid line. And normal is greater than 150. It increases 10 degrees on extension of the neck and decreases 10 degrees on flexion. And it was agreed that a clival-axial angle of less than 135 degrees would constitute a abnormal, potentially pathological condition. Scoville said that angulation of the brainstem causes neurological disability, and Van Gilder said that a clival-axial angle of less than 150 degrees was associated with deficit. Menezes pointed out the fulcrum effect of the top of the dens on the brainstem and the prominent bulbar dysfunction. And Millerat showed that 1/4 of his Chiari patients had a retroflexed odontoid. So I won't go into the, this is a paper by Kim, Rekate, Klopfenstein, and Sontag. And they had a series of 11 patients, young people, who had failed Chiari decompression. And they described these patients as having a form of basal invagination that did not fit the traditional description of basal invagination. And this is what I'm talking about. And in this, they performed flexion extension MRIs, and they noted that on extension, if the patient extended their neck in the MRI, the brainstem tended to fall away from the anterior compressive structure of the odontoid. And so in surgery, their goal was to recapitulate that effect by extending the neck in surgery with reduction to bring the brainstem away from the odontoid process. And they achieved excellent improvement in the neurological deficits in 10 of the 11 patients. So they applied traction and extension. And thereby eliminated the kyphotic clavolaxial angle. And all of these authors have discussed in one way or another the importance of the kyphotic clavolaxial angle. And we performed a rather extensive review of the clavolaxial angle, and also in this paper had a series of 10 patients in an IRB protocol where we showed that correction of the clavolaxial angle was associated with clinical improvement. So we discussed the Grab-Oaks measurement, and in Grab, Mapstone, Oaks, and Jerry Oaks trained about 45% of all the pediatric neurosurgeons in the United States. In that study of 40 patients with Chiari 1, none had traditional basal invagination, but 28% had ventral brainstem compression by this measurement of the PBC2. And they felt that this measurement was a direct measurement of encroachment by the odontoid into the foramen magnum and contributed more to the flattening of the brainstem than the cerebellum. Moreover, the deformity was progressive. So they commented that for patients with less than ideal immediate and long-term outcomes after posterior fossa decompression for Chiari, that ventral medullary compression should be considered as a cause of the neurological deterioration. So if they didn't get better with decompression, think about ventral brainstem compression. And Dr. Kobe discussed the Harris measurement, which was based on 400 normal subjects, and everyone, all of the normals on X-ray had a distance from the basion to the posterior axial line of less than 12 millimeters. So on an X-ray, if you have 12 millimeters or more, if your Harris measurement is 12 or more, then you have instability. This patient has a Harris measurement of 15 millimeters. And Dr. Kobe also discussed translation. There's a corollary to the Harris measurement, and that is that between flexion and extension, the basion, the base of the clivus, pivots over the central point of the odontoid, and it shouldn't translate more than 1 millimeter. According to Wiesel Rothman, Varon, White and Punjabi, and Fielding, and Menezes. So when you have when you see that basion traveling or translating over the odontoid more than 1 or 2 millimeters, then you have some degree of cranio-cervical instability, like this patient, where flexion, the BAI, is 12 millimeters, in extension it's 7, so there's 5 millimeters of movement, and that represents some degree of cranio-cervical instability. Now, a lot of our patients have C1-2 instability, and in Halko's review of just 5 patients with vascular EDS, 3 of them had atlantoaxial instability. And just last year, my own nephew, age 32, I never knew he had any medical problems. Turned out he had C1-2 instability due to Ehlers-Danlos syndrome. And after seeing many doctors and being told it was psychosomatic, he came to see me. We made the diagnosis. I sent him to Georgetown, where they agreed, and they performed the surgery, and he did extraordinarily well. So to look at the alar ligament, unlike the transverse odontoid ligament where we get simple flexion extension x-rays, alar ligament requires a rotational view. So we put the patients in a CT scanner, bend the head right and left, and then look at the axial views, and here's the C1 rotated 85 degrees, C2 rotated only 40 degrees, so that's a difference of 45. And when you get above 40, the blood flow through the vertebral arteries is decreasing, and somewhere between 40 and 45, there is no flow through the vertebral arteries. So we consider 42 degrees unstable in the adult, not the child. So there's unstable. And note also the loss of facet overlap. Fielding says when there's less than 20% facet overlap, you have a subluxation. Obstruction of CSF flow is another important indicator for militating toward surgery for these patients. And we don't just look at Chiari, but even a low-lying cerebellar tonsil can obstruct the CSF flow. And the position of the patient, the presence of foramen magnum stenosis, or even C1, C2 instability, if there's a loss of alignment, that can cause obstruction of CSF flow and neurological symptoms. So before operating on these patients, we like to see more than two of those findings that I've been discussing. So the indications for a cranio-cervical fusion in the EDS patient should be the same as any non-EDS patient. They should, in the EDS category, they should have maximized non-operative treatment, and they should understand that surgery is the last step, and there's no going back. But they should have a disabling headache or neck pain, usually both, and the cervical medullary syndrome of patient symptoms, and demonstrable neurological deficits, and not a carpal tunnel or a peripheral neuropathy, but deficits that can be attributed to the cranio-cervical junction, and congruent radiological findings. They should have all of those before they're considered candidates for surgery. So the caveat here that has already been mentioned is that where loose ligaments are concerned, you need dynamic imaging. So on the left, patient looks tolerably not bad, and that scan may have been read as normal, but the same patient on the right in flexion shows a clear finding of basal invagination. The surgery for this is, we use sensory evoked potentials, brainstem auditory evoked potentials, do a limited suboccipital decompression. Rarely do we do a duroplasty. Screw fixation by the Goel-Harms technique. In this series, we harvested rib for the fusion. The average surgery time was 3 hours, and the blood loss was less than 100 mils in 18 of the patients. We performed, after opening everything up, the surgeon would walk to the head of the table, provide traction, posterior translation, and extension to normalize the clival-axial angle and increase it usually by 20 degrees. And it's very important that the reduction actually not only normalizes the clival-axial angle and decreases the compression of the brainstem, but also very often improves the cerebrospinal fluid flow. So here's our reduction that we do in the operating room. Clival-axial angle, usually about 150 to 160 degrees. We want that mandible to axial interval being 10 to 20 millimeters for optimal swallowing. And we look at the gaze angle, the orbital axial angle, and we made this one up. And that's so that the people are looking in the right direction. They're not stargazing and they're not looking at the floor. And here's the instrumentation, fusion with the ribs. And so how did they do? Symptoms prior to surgery, 100% had headaches, dizziness, arm weakness, neck pain, imbalance, night awakenings, memory problems, gait difficulties, arm numbness, Raynaud phenomenon, leg visual, leg weakness, vertigo, hearing problems, speech, micturition problems. The patients actually tended to heal better than we expected. And at 2 and 5 years, in looking back, would I still choose to have the craniovertebral fusion? Most strongly agreed, and varying degrees of enthusiasm. And the same with, I would feel comfortable recommending the craniovertebral fusion surgery to a family member. One patient disagreed, and I don't know why. My quality of life was improved by having the craniovertebral fusion surgery. Most of these patients had many other medical issues. The surgery improved my symptoms and decreased my limitations. 2 patients disagreed because of the number of comorbid conditions wherein they did not enjoy an improved quality of life. Fusion rate was 100%. Symptoms improving after surgery: vertigo 92%, tremors 87%, fainting, headaches, balance, speech, numbness, neck pain, dizziness, memory problems 69%, walking 69%, numbness in the back, swallowing problems 63% improved, hearing 61%, arm and leg weakness about 60%, and some enjoyed improved vision. So looking at headache, there was a statistically significant improvement from an average 8 to an average 4.3 or something. And recall that these patients have not just headache from the craniovertebral problems, but a lot of them have migraine, they can have venous congestion, and temporomandibular joint syndrome, mast cell activation syndrome, many causes. In terms of weakness, those who were weak before surgery, 94% had improved arm strength, 84% improved leg strength, reflexes, heel-to-toe walking, sensation, and Romberg sign improved in about half patients. Of those who did not have weakness before surgery, 5 to 10% were weaker on follow-up. Now, this is perhaps the most important scale, the Karnofsky performance scale, and 0 is dead, 100%, or 100 is normal. And we saw a statistically significant improvement from an average of 50, a very disabled patient, to an average of 78, so that many of these patients were able to go back to useful work. So looking at some of these, first patient there is in school doing research, next patient online school part-time, third in school waitressing, next not in school, next one not in school or working, next one fully disabled, next one part-time job, next one disabled, next full-time job, full-time student, working part-time. You get the idea. Overall, 12 of the 20 patients went back to some useful work, either in going back to school or going back to work. Reasons for no improvement included other medical problems: fatigue, dysautonomia, endometriosis, dystonia, intracranial pressure, multiple joint dislocations, vascular issues, adrenal insufficiency, and other endocrinologic issues, recent motor vehicle accident, and other surgeries. 15 of the patients had rib pain from the rib harvest site, so we stopped doing that. Now we use allograft. 2 had a superficial wound infection. 1 needed a blood transfusion. There were no other injuries in surgery, and pain over the instrumentation. Over the next 4 years, 8 patients wanted the hardware removed because the prominence of the hardware was causing pain on the back of the head. And now we use a low-profile system. We improved the clavilaxial angle by 20 degrees, and all of the other measurements were also brought into normal range by virtue of the open reduction. Now, how reliable are the radiological metrics in predicting the need for surgery? So here's a patient with a bad-looking Chiari and a stretched-looking brainstem, and I would have thought she really needs surgery. But her pain level was like a 4 or 5, and the neurological findings were very minimal. So I followed her for 6 years, and she's doing just fine. She has EDS. So these metrics, guidelines, they're not rules for surgery. Does fusion cause adjacent segment degeneration? It was very seldom. In fact, we never had to do a C2-3 segment fusion within 2 years. But within 5 years, there were 3 patients who needed extension of the fusion down to T1. Most of, or perhaps all of the patients I see have premature degeneration of all the discs in their cervical spine. Does fusion cause disabling loss of range of motion? The problem with EDS is too much range of motion, and none of my patients have complained about loss of range of motion. This lady had a cranio-cervical fusion, and that's 6 weeks after surgery. In conclusion, it's well established that mechanical deformative stress causes dysfunction of the brainstem and upper spinal cord. And this presentation is the application of that principle to this hereditary hypermobility connective tissue population. And dynamic imaging, flexion extension imaging, is necessary to demonstrate the mechanical deformation of the central nervous system. And reducing that deformative stress appears to be associated with reduction in number and severity of neurological findings and pain. And so why do I continue to treat these patients? It's to take this girl to that. So thank you for your attention.